you.
Thank you. Thank you very much for joining our 9th Health Security Dialogue hosted by Global Health Innovation Policy Program at GRIPS. My name is Hiromi Murakami of Global Health Innovation Policy Program, facilitating this dialogue series. We're honored to welcome a very distinguished guest today from Kenya, Professor Miriam K. a legend in global health arena. Japan has just announced additional contribution to COVAX facilities, while Japan continued to struggle managing COVID-19. Today, we are so fortunate to have Professor Miriam, who is a very close friend of Japan, and she was the first laureate of Noguchi Hideo Award. She will give us a talk on Kenya's experience. We're so excited to hear from Professor Miriam, how public health expert and medical doctors sees the situation, because all the nations are so occupied with their own national situations, and we sincerely appreciate information on the ground, how people are dealing with COVID-19 in Kenya. The purpose of this dialogue series is to build a community for sharing knowledge and experience and discuss how to best prepare for the future health crisis and build health resilience. We'll have Q&A session in the remaining time. For administrative announcement, please submit your questions in Q&A column of the bottom of your screen so that we can address your questions appropriately. Now, I'd like to pass microphone to Dr. Kiyoshi Kurokawa for a welcoming remark. Dr. Kurokawa is a director of Global Health Innovation Policy Program, who is a longtime friend of Professor Miriam K. Please.
Thank you, and welcome, Dr. Miriam K. I think, in fact, we met first time through your CVs and your achievement. And some time ago, when Prime Minister Koizumi, as a Prime Minister of Japan, usually they go to Africa, at least, to visit African Union, Ethiopia, and one more country, I think, during this trip. And then Prime Minister Koizumi thought about Hideo Noguchi because he left a big legacy in Africa. So he chose to visit Ghana at that time. And when he arrived in Ghana, he thought about the great contribution of Hideo Noguchi. Almost every Japanese knows about Hideo Noguchi. But then he thought about creation of some prize of Hideo Noguchi Africa Prize, who is focusing on one of the contributor for the health of Africa. Perhaps two persons. One is some of the medical research area who made a major contribution to improve African infectious disease and this area. And another was somebody who has contributed to the major extent in African healthcare system or whatever public health domain. And I was asked to chair this sort of selection committee. And I think we solicited many sort of nominees from Africa and elsewhere. And we spent many hours with the committees. And in the first inaugural laureate in medical research area was Brian Greenwood from UK, and another who has contributed to the betterment of African health program and healthcare, more like public health domain, was great Miriam K. We are both impressed by their contribution and what they have done, and we become great friends during that time. The ceremony of this award ceremony was held in junction with Japan and Africa issue, and that was done some 10 plus years ago, and we had a great celebration and in the presence of Imperial House, which is perhaps a very rare prize for the Japanese government. And we met Miriam and his families, and that was a great moving moment for us. And Miriam at that time already has Uzima Foundation to continue her effort to make a better healthcare system in Africa and Kenya in particular. And I think later I had the opportunity to visit Kenya, Nairobi, and met many people in Uzima Foundation, very passionate young people who are really trying to make health better in the country. Welcome, Miriam. Good to have you with us.
Thank you very much.
Okay, so let me provide the brief introduction of Dr. Miriam.
Yeah.
Professor Miriam Ware worked for Ministry of Health as a medical doctor and the Faculty of Medicine and the University of Nairobi to teach community health. She graduated public health at the Johns Hopkins University in Baltimore, Maryland, US, with the master's and the doctor's of public health. Her thesis for the doctorate was people's participation in their own health care and development. The project was adopted by the Ministry of Health as a national pilot project for community-based healthcare, which subsequently became a service in Kenya's Ministry of Health and other countries. As head of the department from 1982, she established the Master of Public Health course at the University of Nairobi as the first Master of Public Health course in Kenya. For international arena, she worked as a head of health and nutrition in UNICEF Ethiopia, the representative and chief of mission for the WHO in Ethiopia. Currently, she is a member of the Champions of AIDS-Free Generation in Africa, mostly made up of former African head of state. She's a co-founder of Uzima Foundation Africa with a focus of youth empowerment. And as Dr. Kuroka mentioned, Professor Miriam Ware received Japan's Order of Rising Sun with neck ribbon and Hideo Noguchi Africa Prize. Other awards are Queen Elizabeth II Gold Medal for Public Health, George G. Talbot Award for the National Council of International Health, and many others. We greatly appreciate that you're taking time for us today, and it's all yours. Thank you. And I'll be sharing the slides.
Thank you very much, Dr. Makarami, and thank you, Professor Kurokawa. It's a great pleasure to be here. And I would like to introduce my nephew, who is a virologist, Dr. Samuel Hamadi. I thought that I would be safe with him here in case people ask virology questions that I don't know. He works with the Kenya Medical Research Institute in Kenya. It is a pleasure to be part of this dialogue on health, global health security, because the more I live, the more I realize that we must have a global approach to health. Any place which is in poor health is a danger for everybody else on the planet. Next, please. First slide, please. First slide. Kenya has had, next, please. No, number one. Yes, Kenya has had 3 waves of COVID-19. The first wave was in, as you can see, we have had over 165,000 cases. We have had over 3,000 deaths, and most of our infections have been local transmission, but we have had some imported cases where people come in when they are already infected and transmitted to us. So, but we have had it in. So this is the situation that we have had experience with COVID-19. Next, please. Next, please. So this COVID, the first wave was in August 2020, and the second wave, which was higher than the first wave, was in November 2020. And the third wave, which was in May 2021, is even higher than the other 2. So although so it's still a challenge that we are on the lookout in case things get out of hand. Next, please. Now, when you look at this graph of Kenya and other countries, you see that some countries, they are too small for us to read, but some countries have got very high levels of infection. Kenya's infection is low, but still, as I have said, it has resulted in very many deaths. So Kenya is right close to the bottom of the graph. So we have not yet, at least the confirmed cases are not as many as some of the other countries, but we still have enough to worry about. Next, please. This is just to show you that the period for 100 deaths to occur has been getting shorter. At first, 8 months ago, it used to take 32 weeks to get 1,000 deaths. Then it took 5 months to take, or 20 weeks to have 1,000 deaths. And recently, it takes only 2 months to have 1,000 deaths. So the interval, the period in which to get 1,000 deaths is shortening. And that is a worry to us. It's getting shorter, which means more people are dying. And that is a worry to us. Next, please. Now, Kenya is, the infection is not spread equally all over Kenya. It is mostly in Nairobi, at the coast near Mombasa area, and then in the western part of Kenya. These are also areas which have got the biggest population in Kenya. So we are experiencing a situation where the infection is mostly in the densely populated areas of Kenya. Mombasa area, Nairobi area, and western part of Kenya, which is the part next to Lake Victoria, which is also a part which neighbors our other countries along Lake Victoria, Uganda and Tanzania. Next, please. This is just to help us see the number of men and females, the proportions that of the infection. First of all, the infection, we find that our peak, the majority of those who are infected are in the age group 30 to 39. So we are not experiencing what was said over 60 as the peak, but it is 30 to 39 are the peak. Then the 40 to 49 is next, and the 20 to 29 is next. So those below 10 are a small majority. Those above 50 are many, but not as many as those in their 30s and 40s. So our main population that is at risk is the people in their 40s, 30s, and 40s. Next, please. This is a distribution by presentations. 55% of our cases who are positive come with cough. That's 6% with fever, and 27% with difficulty in breathing, and 9% without any symptoms. They have no symptoms, but when they are tested, they are actually COVID positive. So we have a range of symptoms that we have to look out for, but we also have to be on the lookout for those who are not have as the asymptomatic cases, those who do not have symptoms but are actually positive. A smaller form, as a small proportion of the positive, but they are there. Next, please. This is the age distribution, as I have already mentioned. The highest age is the 30 to 39, but we have cases of those who are below 1 year, then over 9 years, under 9 years. Then we have the 10 to 18 years are the smallest proportion. Then we have the 20 to 40, then 30 to 39, and the majority, when you put the ages above 60 together, they do form a large number. And you can see that in all the groups, the males are more infected than the females. We have not been able to explain this. Maybe Dr. Hamadi might have some comment on that, but it is quite clear that the males are getting COVID more than the females. As you can see, the males are 68%, the women are 32%. So the males are actually more than twice the females. Next. Then in Kenya, we have 42 counties. And the government wanted to know whether all the counties were equally infected. Now, I can't go through all the numbers, but you can see that the numbers are very different. Nairobi has the highest number, then Mombasa, then Kiambu. And let's go to the next slide, please. And they just keep on reducing. Next slide. To Garissa has a reduced number, and you come to number 47. We have 47 counties in Kenya. And the last, Tana River is 100 only, and Wajir is 96. So these are also, these counties which are in the lower part are also those in the arid areas with very sparse population. They are very sparsely populated, and they are the ones where we have the least number of COVID cases. Next, please. So now let's discuss a bit about the vaccination experience. By March 2021, we had over 1 million doses of the AstraZeneca, which was acquired through COVAX. And the priority groups were the government, over 935,000 people were vaccinated. And the priority groups were the frontline health workers, the teachers, the security officers, and those over 50 years. So those who are invited to be vaccinated were mostly in the frontline health workers, the teachers, the security officers, and those over 50. So next, please. This is just another presentation of the same information. By May 16, 2021, we had over 900 vaccinated. Some of them were. So the challenge that we get from this is that if we need to have two vaccines, two vaccinations or 2 doses of vaccination for each person, then we have only covered 0.9% of the population. So we still have a long way to go towards sufficient vaccination of the population. And this is a concern for us. Next, please. When we look at the people vaccinated, the first group is those over 58 age, and they were given the priority. Then all the others come in the next group. And when we look at the priority groups in vaccination, we have the health workers are the most, but not so much more than the teachers. The teachers are the next, and security officers are the next group. So these are the groups in which most of the vaccination has taken place. So that 17% of those vaccinated were health workers because of the fear that they are exposed to the infection and might get infected. Next, please. Again, this is vaccination by county, just to keep track of the fact that how are the counties doing with respect to vaccination. And this shows that, again, Nairobi has got the most vaccination, then Nakuru, which is our next town, then Kiambu, and so on. So we can see that the vaccination is not uniform county by county. And so for the public health workers, they can focus to see how to improve vaccination in the areas where vaccination is very, very low. Especially if we look at the areas which have no vaccination, then you can organize to step up vaccination in those areas where it is low. Next, please. Next, please. Next slide. Next, please. So when we are thinking in terms of the number which was vaccinated, the target was health workers was 208,000, and we have vaccinated only 162,501. So it means that we have at least reached 78% of those vaccinated. The security officers who were not able to get the target, we only know the number that has been vaccinated. The teachers, we have the number, the target that we would like to get vaccinated, which is over 300,000. And we have only vaccinated 44% of the teachers. Those above the ages of 58 years, we should have more than 2.5 million vaccinated, but we only have 284,000 vaccinated, which is only 11%. So if we look at the vaccinated number, which is 933,826, we have a target of over 3 million. So we have vaccinated only 30% of the people that we think should be vaccinated. So we still have a long way to go. And as I mentioned earlier, if you look at the total population, those who have been vaccinated are only 0.9%, less than 1%. But if you look at the target population, then we are 30% vaccinated. So we still have a long way to go. Next, please. So as an overview, we have a cumulative total of 165,000. Fortunately, we have had recoveries, 113,000 recoveries. We have over 3,000 deaths with a death fatality rate of 1.7. We have over 1 million tests conducted, 1.7 million tests conducted, and we have over 900,000 vaccinations, which I have already mentioned. So I think that the encouraging information is that there has been a fairly well-kept record of what is happening in terms of and so on. Next, please. So what are some of the challenges and future prospects that we are facing? One of our challenges is that we don't have complete total population coverage with health services. So when you don't have complete coverage of population, then it is difficult to enforce basic public health measures, such as wearing masks, keeping distance, and washing hands. So one of our challenges is how do we increase population coverage with health services? One of the problems for us as a public health person is that I have not been given a clear sampling process. I am told 30% were found or 10% were found positive, but the sampling process to say this is the sample from which we took this sample from such and such a population has not been clear. So that makes it a bit difficult to have a good idea of where exactly the problem is.
もしもし。まあ、
No,
ちょっとすいません。
the-
後です。いやいや、今ね、アフリカでやってるの、ケニアとやってる最中なので、ちょっとすいません。後でしたいと思う。
we think that if we move testing, antigen testing, so that only those who are positive and with symptoms go to PCR, it will reduce them, it will cut down the cost. So far, everyone is being tested by the PCR test. Maybe Dr. Hamadi will talk a little bit about that one. And right now, the challenge is vaccine availability. And especially since there has been a ban on manufacturers from India now, we actually have a serious problem with vaccine because what we used was from India. So we really need to have the government negotiating on long-term basis how to meet the vaccine availability. And then from a population problem, we need to reduce the stigma. People are very afraid of the idea of COVID. There's just so much fear. And so people even fear to go for the vaccination because they think that will give them COVID. And so we need to deal with the population issue of stigma here. And then of course, the economic impact has been very severe in Africa. A lot of businesses are closing down. When there is a lockdown, we have had at least 3 lockdowns, and it is a really serious problem. And so we need to think systematically, how will the economy be recovered? How shall we help the economy to recover? Because those of us in public health know that when the economy goes down, health problems go up. So we need to think about the whole issue of the economy and health. And since the economic well-being is going down in Kenya and in Africa, how shall we deal with it? And for me, the most serious problem is the fact that we have actually a community health strategy, a community health approach. But it's just around 60% of the community units actually have established health facilities. So we need to move to 100%. If we move to 100%, then we shall be in a situation to say everybody has some access to healthcare, basic healthcare. Community health workers become very important where they are to give information, to motivate people, to follow up, and to keep household accounts of situations, even to monitor infection and to trace those who have made contracts. But when you don't have community health services, when all community health units are not functioning, then you don't have people to do that, and then you are in the dark. So getting community health services effective in 100% of community units is one of the big challenges in Kenya and in most of Africa. And finally, I think that we have the challenge of getting global recognition and acceptance that an epidemic anywhere endangers everyone. If we really accept that and think in terms of the global health security, then I really appreciate the fact that there is this dialogues take place, that the Global Health Innovation Policy Program has these dialogues on global health security, because we have to look at health as a global challenge. A country which has got an epidemic, it can spread to anywhere. And we need to help countries to be prepared to meet their challenges in epidemic challenges, as well as to be prepared in response. Now, the response to COVID-19 was very poor, even in some of the most developed countries. And in a country like ours, we were quite surprised that we have been working, trying to catch up with the COVID. But it is time that the global community thinks about how to respond to epidemics and the pandemics in a systematic way, so that every country is assisted to have a preparedness in it. So I was happy to hear that Japan is increasing its support to COVID. And I hope that some of that support will go to the community level so that we can establish community prepare and then go to the government level in terms of country preparedness for the next epidemic. As we respond to this one, how are we going to be prepared for the next one? So these are the comments that I wanted to share, and I'll be happy to hear from you. Thank you very much.
Thank you very much. It was very, very comprehensive. Let me start a question. First question. You mentioned that the vaccine speed is kind of slow, and although I think the percentage for the health workers is much higher than I think Japanese cases, but with this, you know, what would be the bottleneck? Is it the lack of vaccine itself, or is it more of the personnel or the procedure giving a vaccination to people? What is the bottleneck of getting slowness of this vaccination in Kenya?
I think the bottleneck is at two levels. One level is that it came in a bit late, and there was not enough public information about it. So that's one bottleneck. The second one is the stigma that we mentioned, that people have become COVID just kills you. Yeah, now people are afraid of the word COVID. So even if you hear COVID vaccine, if you are a person who doesn't know really what a vaccine is, you think you are going to be given the disease. So there is the information, the lack of information on the part of the population, as well as the stigma connected to COVID. So we need to approach it from the information point of view and from the stigma point of view.
Yeah, and additionally, I just want to add that also there have been challenges of getting the vaccines because the first doses are provided early this year around between end of February and early March, and they got finished, and as has been shown in the presentation, only a targeted group was being provided with the vaccination, the priority groups. But apart from that, even some of the priority groups did not get the first dose of the vaccination because they can't get out of the vaccines. So that has also been a challenge. And as you're aware, in Africa, we're only getting 1% of the vaccine, of the total vaccines. I think it needs to be worked on. Thank you.
Right.
Thank you. And we have many questions. Dr. Kuroko, do you like to comment or?
Well, not really. I think we are really suffering. I think one of the issue was now this COVID thing started a year ago. Now already years from Wuhan in China and spread out to pandemics all over the world. And now in this hyper-connected world, we could share and see what's happening in other countries. And we might pick up as much as possible or the better response which may have happened in other countries. So this we are really sharing how to combat with this thing. Vaccine is one thing, but also whatever we could do, I think we might follow and learn and sharing the better practice and response across the world. That's I really like to do.
Okay, so we have many questions. So we'd like to tackle the questions from the top here.
Sure.
Okay. One question said, I have heard the number of infectious people are large, but not so much in death in Kiberia slum. Do you think that it can be said that some strong immunity there in your country? How would you strengthen the supporting system in slum area against the infectious disease, including COVID-19?
Yeah, so we're actually doing some studies to find out why population are disappropriately affected with COVID-19. And some studies have actually shown that a big proportion of people, even in the slum areas, have antibodies against COVID, meaning that they have been exposed. But a significant proportion of them are actually asymptomatic. And studies are to show why we may be having this scenario where people are exposed, but we have low numbers. Some of the reasons include the population, the age of the population. We have many of the people living in the slum are younger people compared to the older population. But also there's another issue of what we refer to as immune activation, where some people have been exposed to, some of the populations in Africa have been exposed to other pathogens that are similar to COVID, and this may be protective against COVID-19. But this at the moment is a theory that has yet to be confirmed. But I think the biggest issue is the differences in the population age. And then in terms of management of COVID in the slum areas, because people live very close to each other, it's very difficult, like wearing masks, hand washing. There are challenges of even buying the masks in the first place because these people are low income earners, and majority of them are jobless. And then second, there's also challenges of accessing water. So I think some of the things that can be done in these areas is just to like provide water bins where people can be washing their hands, and the government has been doing this in some of these slum areas.
Right.
Thank you. And we have also the question about the border control. One says, this looks larger number of infectious people in the Western area. How is the border control of Uganda? And then also Mombasa and Nairobi are also entry point from outside countries. How do you access the border control? Is the reason more on the population densities or more border control issue?
The entry into Nairobi is mostly by air from outside. So there has been some regulation of air of the flight to Kenya. Mombasa is also by flight and by sea. We have found, for instance, when we had the Indian variant of COVID-19, it was first seen in Kisumu, which is close to the Lake Victoria on the western side of Kenya. So it was surprising that, how come a Indian variant is in Kisumu? And then it was traced to people who had just flown in. They had flown into Nairobi and then flown to Kisumu from India. And that is how the contact tracing showed that it was connected to those people who had come to Kisumu from outside, and now it has spread in most parts of the country. So movement is an important thing, and unfortunately, when you reduce movement, you also reduce the economic activities. So the two are linked and quite a challenge to manage.
Yeah, and additionally, some of the border areas like around Mombasa and some of the places like Namanga, the border with Tanzania and other areas, we have testing points where like the truck drivers go and they get tested. But apart from that, those are just the controlled border points. But we have other porous border points where people cross over, even with their animals. So it's very difficult to have a formal border control, especially in a setting where some of the borders are porous.
Yeah, right.
You'll see that in many cases, because of the cross-border movement, you'll find that, and because of the high density of the populations, people are doing business, you find that these are becoming some of the hot points for the spread of the COVID-19. And that's why you'll see the spots where the infection is higher because of the movement of the people and the commercial activities that they're doing there. So it's a big challenge to control, to stop movement, and at the same time, people want to eat and they want to continue their lives. So there's a balance that needs to be struck, but it's a significant challenge. Yeah.
Okay, and we have another question. You mentioned about the vaccination for healthcare workers, and it looks very high, like 78% has already vaccinated. So is it not only cover doctors, but also do they cover community health workers?
We'll cover mostly doctors and nurses, midwives. It has been mostly those working in facilities. Definitely, community health workers have not been included systematically. So these are really facility-based health workers who are likely to receive those who are infected. So, so that is actually higher than if you consider all the health facilities, the health workers at the community level. As far as I know, the workers have not been vaccinated.
Yes, so these are mainly the formal health workers, but the informal health workers, so to speak, like the community health workers, a significant of them has not been vaccinated, even the first time. So as she has said, this is mainly a proportion of the formal workers, like the doctors and nurses, and mainly on hospitals and the big health facilities where most of the cases go to when they are reported.
Okay. And we have a question regarding universal health coverage. This is great idea, but sounds very impossible. And but the revolutionary idea seems so at first. So what will it take to make this happen in Kenya?
Universal health coverage is really a wonderful idea. And in my own work in community health, we have seen that where you cover the community in a geographical area, you actually reduce disease. You reduce child death, you reduce maternal death, you reduce malaria infection. So it is something that is workable. But the problem is that, and unfortunately, countries which are which are not very rich have been able to do, like Ethiopia has almost 100% coverage over the village with health extension workers. And Rwanda has it. Unfortunately, in Kenya, we don't have yet. As I said, it's about 60% communities are covered by community health workers and community health services. So in Africa, I think the approach to universal health coverage must be, the first point is coverage from the community level. Because a lot of our diseases are preventable. Malaria is preventable. Measles is preventable. Polio is preventable by immunization. And if you can have community health services and take care of those preventable diseases, then you are already moving as many steps forward towards universal health coverage. And then you have the facilities, health facilities. But you see, the problem is that the focus has been on health facilities, especially expensive, top-level health facilities, and most of the money goes there. But those are taking care of only 1% of the health problems, but most of the money goes there. But if we were to change it around and make most of the money go to the community health level, then our prevention market and community health, universal health coverage would work. That is the dream that has to be achieved. And really, because we seem to be trapped in focusing on high cost health services, I hope that our international partners, especially a partner like Japan, which has really helped Kenya, has really invested a lot in the health of the population, can focus more on getting the community health services functioning as a focus. Then, if we can do that, then we would move forward and have a chance for universal health coverage. So
this question says, you talked about the community health workers, and then you mentioned about stigma. So how would you extend information to all in your country? How do you secure access to vulnerable people, such as people with disabilities or elders who are difficult to walk outside, for example?
Well, in Kenya, we use the radio quite a lot, because the penetration of the radio in Kenya is very high, even in rural areas. So that's one channel we use. The other channel is public. In each administrative area, we have regular meetings on a weekly basis where the administrator, known as the chief and the assistant chief, they organize meetings for their own people. And this is part of it. But in the final analysis, the best approach is to have community health services, because then a community health worker is in a community is trusted by the community, and the community can go to that community health worker. So we have these various areas, but it is, in my opinion, it's not sufficient until we have community health workers in every community, like they have now in Rwanda, like they have in Ethiopia. Then we can then get to the disabled, to the elderly, and so on. Right now, you assume that they are listening to the radio, but we don't know if they are listening to the radio or not. The community health worker, they can actually visit, do home visiting, and see whether the people are getting the information or not.
Okay, so we have another question. Considering the difficulties in increasing the vaccination rate because of stigma or the, the local community health situation, what can be needed strategy or policy in Kenya to increase this vaccination?
I think some of the things that can be done is to, first of all, we need to improve on communication on the importance of vaccination. And we also need to provide evidence that shows that the vaccination is protective. We also need to communicate to the communities and the population that these vaccines are safe, because there is some misinformation out there that may allude to the fact that people are being exposed to COVID-19 when they're not. So it's very important to use the communication channels to improve vaccination. And even in people who are well educated, you still find some of them have this challenge of taking up uptake of the vaccination. So I think we need to really address the issue of misinformation so that we can be able to ramp up the vaccination. And even when the vaccine, even as we do this, we need to make sure that the vaccines are available. Because once you communicate, you need to make sure that these vaccines are available for the people to take.
Okay. And also regarding vaccination, again, some of the vaccination requires, the freezing facilities to store and even carry those things is very difficult. So how do you think, what would be a good way to, of an improvement strategy of providing storage and management of those vaccines?
In fact, that's one of the biggest worries of Africa, is that when vaccines came, we were told that they must be minus 90 degrees, very low temperatures. And most of our homes, we don't have the facility. We don't have refrigeration facility. So one of the things that COVID has brought out is the importance of having energy, having electricity in every household. Now, the most available energy in Africa is the sun. So we need to invest in solar energy with the view of having solar energy in every home. And again, when you have got many priorities and little money, you don't think about those things. So I think that we need to have a global approach to energy, household energy, especially household electricity. I'm involved in another project which is looking at the clean air, the importance of clean air, because cooking with an open fire results in soot in the house and respiratory health problems. And so it would be useful to have clean cooking energy. Now, you can think about gas, but the problem with gas is that it is a fossil oil energy, and that has problems of their own about environmental degradation. So what we think the focus should be is energy from the sun, solar energy. Then how do we do that? That is the challenge that the global world, the global community needs to help us think through and see how we can approach having a global program for household electricity, so that they can be used for cooking, they can be used for refrigeration, and at least for those two. Right now, we are a bit stuck because most of our communities don't have electricity.
I see. And another question, many questions today. So do you think the nutritional level of poorer people worsened because of an economic recession during COVID-19? If so, is it an impact on COVID-19 recovery?
Yeah, so because of the cessation of movement and lockdown, there have been very little movement, and ideally that would affect the economy and also the distribution of food in different places. So in a way, the nutrition would have a great impact on COVID-19 transmission and even the severity of the disease. And actually some studies have shown, and even the supplements that people take, like zinc and the other vitamin C and so forth, these are things that will be naturally found in good nutrition. So you'll find that when there is a limitation of movement, then nutrition will be affected. And it's true that this is also having an impact on transmission and the severity of COVID-19. Yeah.
Okay, so we have one more question. Okay, I have heard that the quarantine is not working properly because there is no food providing during the quarantine when the test is positive. How do you plan to improve the situation?
This is really something, because during the lockdown, I was in the rural areas, in my home in the rural areas at one time, and I was there for 5 months continuously, which is the longest I have been in the rural areas since I was 12. And this became a reality that if people don't go to the market, they can't get food. And so they look at you and they think you are in a position to supply them with food. They come to your house. And so a lot of the children were just coming to the house. So we couldn't even protect ourselves from COVID-19 because they are coming. What do you do with them? And unfortunately, I have to say this, sometimes there was funding provided for the very poor families, or there was a national program that we are going to give poor families some money. But we don't know if that money was ever given or not. And if it was given, it didn't get to the people, because people would come to ask me in the village. They would come to my house and say, you are from Nairobi, why can't you ask them to press us money? They took our names, but they have not sent money. So the whole issue of guaranteeing food to the household was a problem. And the whole issue of integrity and corruption, it gets linked into all these things, because somebody didn't send the money to the poor people. At what level was it? And I'm not an investigator, so I couldn't answer that question. But either it didn't come from the head or from the national level, or if it got from the national level, it didn't get to the people. So the whole issue that these emergencies tend to strengthen corruption programs. So we need to deal with the corruption issues. We need to help people to understand the importance of integrity and the fact that when you are hurting your neighbor, you are hurting yourself. And that message has become very clear to me, that integrity is really so core. Sometimes I admire Japan very much, because all that I have read about Japan, people seem to be very honest. And it is considered kind of a disgrace to lie to people and to steal. I think that's the impression I get. So you have to help us get to the integrity level. Integrity is very important, and we're struggling with it. We have to show that it pays to have integrity, so that it becomes attractive. I don't know how we are going to do that, but we are going to try. We are trying. The only way I know is a spiritual approach. And sometimes the international community doesn't like supporting spiritual approaches. So I don't know how we are going to do that. Maybe Japan can tell us how they did it. Did they use a spiritual approach? And can the rest of us use the spiritual approach, so that we can promote integrity and get rid of corruption, or at least reduce corruption?
Okay, yeah, it seems like it's a very complicated issue, not only just vaccine, but it's a stigma, and it's community health, and also corruption and poverty and basic infrastructure. so much of things that tangle each other. So we'd like to give Dr. Kurokawa for the final remark, and that will be the end of this dialogue. So could you, Dr. Kurokawa, can you unmute?
Right. Okay.
Okay.
Yeah, thank you, and Miriam. I think it's good to see you again and your leadership in that area. But if you go to, let's say, Africa, I think Nairobi is a big city. But I think if you go outside of this thing, it's a very hard way to reach out, and how you do this sort of immunization, all the things. And I think I'm really like your leadership through Uzima. I saw that. I went to Nairobi 3 times, I guess, but I think there's a great school and great leadership, but I think still urbanization and outside is very hard to reach. And I think there's a big slum area too, and Kibera slum. But I think there are many challenges. I think I really admire your leadership with your foundation, and also Uzima Group really nurturing and educating future many youngsters working there. I'm very impressed by your leadership, and thank you very much for joining this session.
Harvard Kennedy, yes.
All right, thank you. And I think when you come to Japan, always you come to Fukushima to meet Noguchi Hideo. That's a great thing too.
Thank you.
Very final word, because you talked about the necessity of systematic way
Right.
to tackle this issue, not only one country but the global world. What would you want to tell those audience who are listening to your talk, from your perspective? What do you want to tell them? What do you want to ask them to make action or final?
Right.
For me,
Yeah.
I really like this global approach, the Global Health Innovation Policy Program.
Right.
It's a very important program.
Mm-hmm.
I like the idea of global dialogue on health security. We have to have a global approach. In other words, you see, I have seen this in emergencies. When you are in an emergency, on the most visible things. And unfortunately, many of our countries are, in terms of economic, they are dealing with emergencies. So they try to do those things which are politically most visible. Like if you build a hospital and you have a big dialysis machine, it is more visible. But so we need the global approach so that those who are not in an emergency, the countries are not in an emergency can help us address the more basic
Hello? I think the line is
forest the whole day looking for firewood. It would provide forest. It would do so many things. So I'm happy you have met my nephew.
Great.
Sorry,
Great
my
to
line
see you.
was unfortunate.
Yeah.
Thank you very much.
Thank you.
Thank you.
Thank you.
Hope to see you soon.
Right.
Be safe.
Stay in touch.
Thank you very
Thank
much.
you.
Bye.
All right.